All right. Hello, everybody. This is my first Instagram Live. Welcome. I don't know if we're going to have any guests today, but we're going to talk about endometriosis. Now, I have to let me add Dr. Leon here. Let me see. Where is he? There he goes. Dr. Leon, you should be able to. Yay! How are you?
I'm good. Can you
Can
hear
you
me?
hear me? Yes, I can hear you. But hold on. This is weird. Can you hear me?
I can hear you now.
Okay. It's very weird because I have these headphones on and it's connected. Hold on, let me just turn them off. They're connected, but I'm hearing you through my phone. Okay. Can you hear me?
I can hear you now.
All right, sweet. Well, thank you for doing this, for agreeing to do this. I know that this is not necessarily your comfort level, but
No, thank you. Thank
but
you for having me.
yeah. But anyway, as you probably know, it's Endometriosis Awareness Month. So I've been seeing lots of posts from lots of endometriosis groups and surgeons and whatnot. And I figured since you're my favorite endometriosis surgeon, we should talk about it.
Definitely, I'm excited.
All right, awesome. Okay, so if you want to just introduce yourself and let us know, who you are, where you work, where you trained, and then I can start asking you some questions.
Yeah, my name is Mateo Leon. I'm a gynecologist practicing in Houston, Texas currently. I did my OBGYN training here in Houston at UT Houston, and then I did my fellowship in minimal invasive gynecologic surgery at the Mayo Clinic in Jacksonville, Florida. And currently, my practice is mainly minimally invasive gynecologic surgery. I see a lot of patients with chronic pelvic pain, just pelvic pain in general, needing fertility surgery, needing surgery for pelvic pain related conditions. And so that's the bulk of my practice. And that's how I met the great Dr. Belizaire.
Unfortunately for you. Just kidding. No, it's been fun actually working with you. So, question, what is minimally invasive gynecologic surgery other than the obvious? Like what is it that you learn in that fellowship that's different than just the general gynecology residency?
Yeah, that I think that's a very relevant question. What you train on essentially is in performing complex pelvic surgical procedures in women, and that includes complex endometriosis surgery, complex fibroid surgery, the management of not only in the OR but the management of chronic pelvic pain and the different possibilities there are with that. Also hysteroscopy, complex hysteroscopy procedures. So it includes all the complex surgical procedures in the female pelvis.
Gotcha. Okay. And how long is that fellowship?
It ranges between 2 and 3 years currently, depending on the program. Yes.
Gotcha. Okay. And all right. So what made you interested in minimally invasive chronic pelvic pain? Because I feel like when I think about that from a colorectal surgery standpoint, most people try to shy away from that because it can be something that is somewhat complex to actually figure out and treat. So what made you interested in that?
Yeah, and I think it's the same with gynecology. People tend to just, not deal with that. But I think a lot of it is because there's so many unknowns, right? I mean, the pelvis is really a confined space. We have a lot of organs in the pelvis,
Yes.
and it can just get complex and difficult to treat. And I think my interest was born when I saw a patient that I was unable to help really, and
Okay.
so that sort of triggered my interest, and obviously I love being in the OR and performing complex procedures. And so that's how I got interested and went for it.
Yeah. Okay. So endometriosis. So you know, even in general surgery training, we didn't, I know that this is sort of a gynecologic diagnosis. However, when I was in general surgery training, like we never talked about it or knew anything about it from a general surgery standpoint, for sure. But then when I was a colorectal fellow, we also we weren't invested too much in it. It was almost like, oh, if they need us, they'll call us kind of thing. But since I have been in my own practice in the last 2 years, I have found that a lot of the patients that end up coming to my office for like pelvic pain or constipation or things that are seemingly affecting their GI tract, turns out that they have something like endometriosis. And so I find myself having to learn more about the disease process because a lot of the presentations I see are related to endometriosis. So my question is, when you see patients in the office, what is their most common complaint to you, or what is it that prompts somebody to send somebody with endometriosis to you?
Yeah, I mean, the problem is that, looking back to my medical school years, it's not that they place a lot of emphasis about teaching endometriosis. It's really a not well-known condition, even nowadays, right? It's poorly researched, it's underfunded, and it's really poorly understood by not only by patients, but also by physicians,
Yep.
and not only by physicians, but also OBGYNs. And so it is a complex condition. I think it's very important what you are bringing up, because we have to stop thinking about endometriosis as a common gynecologic only condition. It is truly a chronic inflammatory multisystemic disease. It can actually affect a lot of the other organ systems, and we should see it as such.
Yeah, because my understanding is that sometimes people's first symptom of it is like a pneumothorax, like they find it in the chest or something like that. So sometimes they don't even necessarily find it because of pelvic pain, for example, right?
Exactly.
So,
but with that being said, I think the most common complaint is certainly chronic pelvic pain, or pelvic pain with the periods is the most common, but not only during periods, but just constant pelvic pain. It can be also related to bowel movements or urinary dysfunction. People who have pain when the bladder is super dilated, or when they're voiding. And then obviously you can have disease that can reach the diaphragm or the thorax, causing pneumothoraxes, or catamenial, meaning the symptoms only with their periods, when they have, like, for example, cough or chest pain or back pain. So it can present in several different ways. I think the most common presentation is chronic pelvic pain, and it can also be associated with infertility. So that's also a common scenario in which the patients find out. It's that they haven't been super symptomatic throughout their life, but then they get into trouble with fertility processes, and then that's when they get diagnosed.
So that's probably why it's a little bit elusive. Like, for example, when they're having certain symptoms, it's attributed to other organ systems, but then it turns out that it's endometriosis that just happens to be affecting other organ systems. So for those of us that learned late in life what it is, how would you define endometriosis? Like, what is it that is causing all of this?
Yeah, so endometriosis is, like I mentioned before, a chronic inflammatory condition in which a tissue that is similar, not the same, but similar because it's metabolically different, to the endometrium, which is the tissue that grows and sheds with menses inside the uterus, for some unknown reason grows outside of the uterus. So by definition, it's a problem outside the uterus. Most commonly seen in the pelvis, but it can also, reach the bowel, bladder, and pretty much every other organ. And so I think it's important to define it as a problem that is outside of the uterus, because a common misconception is that a hysterectomy will cure it, and that's an absolutely false statement.
Okay, all right. You kind of stole one of my questions there. So why is it that, so do you think that the reason why some patients end up with a hysterectomy is because people just don't understand the basic nature of what endometriosis is, that it is a disease outside of the uterus?
Yeah, I think so. And there's also some historical facts that may have not been,
Hmm.
helpful in that
Okay.
sense. It has been traditionally, there's a couple of theories about how endometriosis happens.
Hmm.
We don't really know 100% how it happens, but there are several theories. One of the older theories, and probably the most common taught, was the fact that people can have retrograde menstruation,
Hmm.
meaning having menstrual flow into the peritoneal cavity and
Hmm.
then therefore seeding the abdomen with endometriosis. Now, I think that has fallen out of favor, and there's a couple of reasons. One is the fact that we know that a lot of women have retrograde menstruation, yet only about 10% of the population have endometriosis.
Hmm.
We also we have seen endometriosis in premenarchal
Oh.
girls, so people who haven't had a single menses and they have endometriosis. And we see endometriosis in postmenopausal women all the time, people who are not longer having menses.
Yeah.
There's also genetic conditions in which they're born without the uterus. For example, the Mayer-Rokitansky-Kuster-Hauser syndrome, which is associated. It's associated. I know that's a mouthful. That's a mouthful, but essentially, that's people that are born without a uterus that is
Mhm.
associated with endometriosis. So if you're born without a uterus, then how can you explain it by retrograde menstruation?
Yeah. Yeah.
So, there are a couple other theories, but that's, I think, one of the reasons why it has been traditionally thought that a hysterectomy can help. Now, a hysterectomy has a role in some of these patients because they can be there can be conditions in which the uterus is affected. For example, adenomyosis, which is
Mhm.
essentially the same disease process that endometriosis, but affecting the muscle of the uterus.
Okay.
And so, if that's the cause, then the uterus is certainly sick and or causing symptoms, and there is a role for a hysterectomy in those patients. And the other problem or common problem that's associated with endometriosis is uterine fibroids. They have a
Oh,
similar genetic origin, so it's not uncommon for people to have endometriosis, adenomyosis, and also uterine fibroids.
I had no idea that it was related to fibroids. So that kind of sends me to my next question. I know that fibroids seem to affect Black women more frequently than non-Black women. Is that also the case with endometriosis?
It's not the case with endometriosis, at least from large population studies. Certainly, for fibroid-related symptoms, yes, there's a lot of problems with research associated with women's health as well. So I think there's a
Let's
lot of
talk about that.
opportunities. There are lots of opportunities
Yeah.
to improve our knowledge in that that matter.
Yeah. Well, that's why I'm grateful that people like you acknowledge that and I'm guessing hoping take that on and I think just I have learned much more about it. I feel like I hear much more about it now and I don't know if that's purposeful or that I'm looking for it, but I feel like the more that I'm considering myself a layperson here because I don't treat it primarily, but like lay people sort of talk about it, the more pressure there will be to like get better understanding medically about it.
Yeah, I
um
mean, I think it's interesting that, there's some studies suggesting that people can go up to like 8 or 10 years without diagnosis or before they reach diagnosis. And I think that that's just mainly because of the lack of education at all levels. And so I
yeah.
think we can do a lot better. I mean, the fact that you, as a colorectal surgeon, is putting up like, conversations like this, I think it's really, really important.
Yeah, yeah, for sure. Well, thank you. Okay, so let me turn a little bit towards, let's say you see somebody in your office, they've never been formally diagnosed. What does it take to get a diagnosis? Is there imaging studies that tell us that, okay, this is endometriosis, or how does that go down?
Yeah. I know. I think the first and most important step is doing having a really good talk with your patient and getting a good history about what their condition is, and their symptoms. Most times, with only that, you can have a very, very high suspicion of what's going on.
Okay.
Yeah, I mean, most of the guidelines have changed in terms of, we're moving away from the traditional diagnostic laparoscopy to get a biopsy to look at under the microscope and confirm it's endometriosis, even though the pathology report is still the diagnosis of endometriosis. We can have a very high suspicion of endometriosis. And the important thing is to determine what subtype of endometriosis the patient has, because there's a couple of different phenotypes. And another interesting thing about endometriosis is, not that it's just in case it's not challenging enough, right?
Yeah.
Is that the amount of disease in someone's pelvis or abdomen does not really correlate necessarily to the symptoms they're having. And so, I have patients that have sometimes terrible disease, invading other organs and things like that, but they have an okay quality of life. They're not super symptomatic. And then I have patients with superficial disease that have terrible symptoms and affects their quality of life significantly. So I think the important thing is there's not an imaging in particular that will determine whether the disease is present or not. I think the clinical suspicion is the most important part, and definitely, surgical pathology would prove it.
Gotcha. And so does MRI tell you anything, or doesn't add much?
It adds whenever you're suspecting the phenotype that's called deep infiltrating endometriosis. And that's just deep disease, thickened, fibrotic disease that can invade other organs. It's sort of like behaves like cancer, but it's not, cancer. And so when you suspect that's present, and you can suspect that by findings through your pelvic exam or your office exam or prior surgeries. By the time people get to me, they've usually had surgery in the past. And so if you suspect that based on prior surgeries or a physical exam, or then an MRI may be helpful in determining where you can find the disease. We have now good enough imaging and good enough protocols to sort of know where and how deep that endometriosis truly is. Especially if we talk about colorectal endometriosis or bladder endometriosis. The important thing is to treat it as in a multidisciplinary team, right? And so that's how I'm gonna tell everyone, that's how I met you, right? I mean, we have good enough imaging to know, how is this affecting the bowel? Is this, if I'm suspecting this patient will need just shaving or just remove the endometriosis from the bowel, or is it truly infiltrating the bowel that we'll need to do a discoid excision or a segmental resection of the bowel? So we have good enough imaging studies now to kind of plan for that surgery and limit the amount of surprises we have in the OR.
Gotcha. Okay. Yeah, nice. Okay. Another question I heard from a patient of mine, a very commonly prescribed medication for endometriosis. I've heard sort of like conflicting things from a patient perspective on medications that are prescribed. One specifically for Lissa, is that like Lupron? No. Anyway, one of the hormonal medications, I believe. What's your thought on medication for endometriosis?
Yeah. So I think the optimal treatment is, definitely surgical, but there is a role for hormonal suppression, mainly for symptoms, to treat the symptoms of the disease. I don't think there's been a research that supports that any kind of medication will actually treat the lesions or making them disappear, but they certainly help with the symptoms associated with endometriosis, specifically the chronic inflammation and pain. Usually these medications are hormonal suppressors that will decrease the amount of estrogen. We know that endometriosis thrives with estrogen,
Okay.
and usually injectable progestins, oral progestins, birth control pills, all of those will decrease the amount of estrogen within your body and sort of help that way. Now, if you're talking about Orilissa, so Orilissa, there's a group of drugs that target GnRH, that's what it's called, okay? And they sort of, the traditional known one is one called Lupron. Lupron is a GnRH agonist, and there are newer drugs that are GnRH antagonists, and Orilissa is one of those. Okay. What are the problems? I mean, I hardly ever use these drugs, and there's a couple of reasons. One is that these kind of drugs sort of drop the estrogen levels to very, very low levels, okay? And that has some problems. That sort of increases the side effect profile of the drug. So people can usually, have a lot of side effects, mainly, menopausal symptoms, vaginal dryness, hot flashes, night sweats, and things like that.
Yeah.
And because of the low estrogen levels, you cannot use those for a prolonged period of time. So for example, Lupron, we use it for 6 months up to a year if you add some other hormone to it. But, in my opinion, endometriosis, I mean, usually these patients are very young, right? I mean, I see adolescent patients with endometriosis, and I think the treatment should be, designed to be long-term and not really for 6 months to a year with that bad of a side effect profile. And I think Orilissa, Myfembree, sort of newer drugs are still new. We still don't know a whole lot about them, but we know about Lupron. There's been head-to-head trials between Lupron and like IUDs and even birth control pills, and they're not even superior to those in terms of symptom control. So if
really?
Yeah, absolutely. So if I have a drug that has potentially a lot of side effects and you can only use it for a short course, I think that it would not be my first choice. I think I still discuss this with my patients, but because of the reasons that I previously mentioned, I don't use them as much.
Right. Yeah. It doesn't sound like the benefit outweighs the potential risk or side effects of those medications. Okay. So then once you've excised the patient, let's say you have a patient that's symptomatic, it's got pain, and you've excised everything, you go in, you excise everything. What is the likelihood, or how often do you see them coming back with endometriosis requiring another excision?
Yeah, that's a difficult question to answer because I think data is all over the place. We don't have a whole lot of data to answer that question. However, let's start with the fact that endometriosis is not a curable condition, okay? Because even if you excise everything that to the naked eye looks like endometriosis, there's still microscopic disease there. That can either cause symptoms or flourish later on. We know that it has to do with the age of the patient too, since we know that endometriosis thrives with estrogen. People who are younger, so adolescents, may have a higher chance of having recurrent symptoms and needing additional surgery. We do know that people who have deep disease, most times that sort of doesn't come like that again. So those are the people that actually benefit more from surgery. But somewhere around 20%, 10%, depending on the articles that you read, but between 10 and 20%, I would say it's probably commonly seen, just as a general number.
Gotcha. And then, you mentioned earlier, this is a multidisciplinary disease process. Where you did fellowship and where you are now, do you guys have anything like not like a multidisciplinary, how you do like multidisciplinary tumor board? Do you feel like that would be something that would potentially be beneficial for patients? In terms of like treating them medically, then treating them surgically, and then having other surgeons involved that may need to help with, any portion of the excision?
Yeah, absolutely. I mean, I think that's key. That's key in the success of the treatment of patients with chronic pelvic pain and with endometriosis. So,
Mm,
so if we talk about the surgical aspect of it, I think it's key because again, endometriosis can affect significantly other systems. And so, you and I have taken care of patients who have colorectal endometriosis. I've worked with urologists who can help if the patient has deep infiltrating nodule in the bladder, etc. You can work with CT surgeons for thoracic endometriosis. So I think it's key to manage it in a multidisciplinary fashion. Now, not only in the OR, but also outside of the OR. So
oh yeah,
people
yeah,
with endometriosis most times have other pain generators that are also affecting their quality of life. And I think we often have to like fight on all fronts to help them improve the quality of life. So a lot of people with
mm,
endometriosis will have also like pelvic floor dysfunction or pelvic floor
mm,
issues contributing to the pain. So I think it's key to partner with PM&R doctors or physical therapists that
yeah,
can help in the recovery and the multi-organic assessment of patients with pelvic pain. Yes, we do have a multidisciplinary team where I currently work at and also where I trained. And I think that's key. There's always things that we can
yeah,
improve. So we've been
yeah,
working on, for example, with our radiologists, right, improving our MRI protocols for the detection of deep infiltrating disease. And I think there's always room for improvement. So one thing that you're mentioning, which is pretty important, is kind of circling back, right, and just
yeah,
meeting with them again and saying, hey, this is what the MRI read was. This is what we found in surgery. This is what we had to do, and this is the pathology report too. So it's just coming together and kind of looking at everything, in a
yeah,
retrospective manner. I think that makes us better and helps us out in the future.
yeah, yeah. Okay, I have a few more questions. I know I told you 20 minutes. We're at like 30 minutes now,
No
but
worries. Go ahead.
you're no, I'm learning so much, so I appreciate you. When it comes to infertility, I know of a couple of patients and actually a couple of friends who have struggled with um, pregnancy, conceiving, and that is the first time they found out that they had endometriosis. Is this something that I guess I don't know how to answer this question, but like, is this something that uh, people who are trying to conceive, like, should they be looking into endometriosis as a cause of inability to conceive sooner? Because I know, quote, infertility is what, after a year of trying or something like that. But like, should this be looked into any sooner? And if they're not having pain, how do you make that diagnosis outside of sticking a scope inside their belly?
Yeah, absolutely. I think an important question. So um, when you have infertility, okay, and if there are signs or early signs of endometriosis, say for example, you go to the fertility specialist, they do an ultrasound and they see a cyst full of endometriosis in one of the ovaries. We have to understand that a cyst full of endometriosis, that is a marker of severe disease. So a lot of people with an endometrioma
Oh,
will have, like we know that 85 to 90% of the patients with an ovarian endometrioma will have endometriosis elsewhere. So I would say if that's the case, then, talk to your fertility specialist about the possibility of endometriosis and how to manage it. And if you
yeah.
need to see another physician, or an endometriosis specialist. Now,
Okay.
say everything looks fine, okay, and you don't have any pain. A lot of the unexplained infertility patients will end up having endometriosis for sure. So I would say that it's not a common scenario, and I think that I would encourage patients to talk to your fertility specialist about that option, especially if you've already had sort of treatments that have not worked. So, I see patients that already have had like, 3 IUIs and 3 IVFs, and they're still they haven't had success. Then
Yeah.
there's probably it's probably time to check
Gotcha.
possible endometriosis. Yes.
And then for those patients that their quote only symptom is inability to conceive, does excision surgery help with their fertility, or is that when the medications, the hormonal medications, will help with their ability to conceive?
That's a little bit of a loaded question, but
I don't know. I'm learning. I'm learning.
no, I mean the short answer is yes. So it depends on a lot of factors, but people tend to think that endometriosis affects fertility by like scarring the tubes, for
Yeah,
example, from
that's
like
what I would
from
have assumed.
yeah,
Yeah.
that can happen certainly when you have severe disease, but really how endometriosis affects the fertility process is just because of the chronic inflammation. So really, even endometriosis that is distant to the fallopian tubes can be associated with infertility. And by removing that, there is a higher chance of spontaneous pregnancy and also IVF success by some newer data. However, this is all very gray still, and I think we're going to need to research it a lot more to have some definitive answers.
Gotcha. I don't feel hopeful about research into women's diseases in this era of American politics. However, I do enjoy that we are having this conversation and that more people are having this conversation. And I hope that, the research follows, because I think historically, as you kind of alluded to, women's health has not really been studied as much as we would have liked. Yeah. Okay, I'm going to ask you one last question. There's a question in the chat, and I'm going to ask you that at the end because that was also a slightly loaded question. But what is one thing that you wish other physicians and providers knew about either endometriosis or patients with pelvic pain, so we could start to educate them before just like offloading this patient that's been dealing with this for decades, when they come see you? So what is it you wish that we knew?
I think that the most important thing is to listen to your patients because I think it's a very, very important subject, okay? It actually can destroy lives, right? I mean, there's
Yeah.
some studies out there that show that, the how this affects patients, it's comparable to cancer and other,
Mm-hmm.
terminal diseases. And so it's a huge burden for our patients. And so whenever in an early encounter in life, if a patient is having, for example, pain during their periods that is affecting their quality of life, that's never normal, okay? And
Mm-hmm.
something that I hear from my patients every single time is that, they were just like, they were told to like just deal with it, right? And it's or that they're weak because they cannot deal with their period pain, and really any kind of pain that is affecting their quality of life, their ability to function.
Yeah.
We have patients that have to miss school, high school, middle school,
Yeah.
or even later in life, their jobs. And so that's absolutely not normal. And I think that finding answers is what we should do. So I think that, listening to your patients and doing early referrals can change
Yeah.
lives.
Yeah. No, totally, when you were saying that, I had like friends experiences like flashing before my eyes. Like I played soccer growing up, and I remember that I had some teammates that like literally had to miss games because the period pain was just so bad. So that's good to know. Okay, I've got a question here. This is from one of my favorite dietitians, Samina. She specializes in dietitian recommendations for patients with IBS, but she also sees a lot of patients with chronic pelvic pain and endo pain. And so her question is, how do you differentiate between IBS pain or like colon related pain versus endometriosis pain?
I think it's hard to differentiate, and a lot of time it actually coexists, so it gets very confusing. I think what I usually do is because I treat patients with endometriosis, I make sure I rule that out. And if I still suspect that there's an IBS component, I would consult with one of my GI colleagues that treats
Mm-hmm.
IBS too. And I think nutrition is a very important factor, not only for people with IBS, but also for people with endometriosis. I don't think there's a straightforward answer about how to differentiate one from the other.
Yeah.
I think it includes just a full workup of what potential causes of pain can that patient be having.
Yeah. Well, you mentioned it, and I'm sure that she's loving that you mentioned it, but are there nutritional nutritional guidelines that you tell your patients with endometriosis?
Yeah, and I think that's very important, not only for patients with endometriosis, but just in general chronic pelvic pain. You know, it's you know, endometriosis is a chronic inflammatory condition. So everything that is pro-inflammation will not help. So, smoking, drinking, carbonated drinks, and things like that will enhance that inflammation and may not help. And diet is the same way. So low inflammation, low inflammatory diets, Mediterranean diets and things like that, and probably our friend the dietitian can help us out a little bit with this, because I think it's a very important aspect of the comprehensive treatment of these patients.
Yeah, for sure. Awesome. Okay, I have one more thing I'm going to ask you. Somebody in the chat asked you, but I know this is also a loaded question. Lots of people deal with this and in the Houston area, and they want to know where they can find you. I guess for the next few weeks, where they can find you, where they can find you in general, because I know you said you don't do a lot of social media, but you are a wealth of information. And one of the reasons I really enjoy working with you actually is because of the way you listen to your patients and the way you approach your patients. And I've spoken to your patients and they tell me that the way you talk to them and the way you approach them, and for me, as like a colleague and as somebody who wants to refer my patients out, it's really important that I know that they're taken care of as like a human being. And so that's one of the reasons I really enjoy working with you. But for anybody out there, where can they find you? Tell us your full name again and where you are located now and maybe later.
Okay. So my name is Mateo Leon. I'm a gynecologic surgeon at UT Physicians in Houston, Texas currently, and I'm going to be there for the next couple of weeks. And I'm relocating to Jacksonville, Florida pretty soon. So that's where you're going to find me.
Everybody in the chat can boo. No, they're very lucky to have you. I'm excited for you. I'm sad for me, but I'm excited for you. And those patients, they're very lucky to have you. So,
But
yeah.
I just want to mention that it's been great. I've found great partners and great surgeons that have helped me in our commitment with these complex patients and this complex disease. So shout out to Dr. Belizaire for being so brave and awesome.
Oh, well, thank you. And thank you, everybody, for joining. I appreciate it. And I don't know, just because you're in Jacksonville doesn't mean that we can't do this again. So good luck with your move to Florida, even though I disapprove. And we'll do this again sometime.
Absolutely.
All right. Thanks, Mateo.
Thank you.
All right.
Bye, everyone.